can, there you go. So we're recording this meeting for posterity. I'm John Ellis. I'm the course director of Anesthesia Camp. I have faculty appointments at the University of Miami, where Dr. Dudaryk is, as well as at the University of Pennsylvania. Some of you have gotten postcards in the mail for our meeting for January 2025. You may have seen this fun one here that went out a few months ago, and this other one that went out. And again, you can sign up for the meeting at destinationcme.com. We have a fabulous faculty. I'm the medical director. We have Dr. Joshi from UT Southwestern talking about GLP-1s and ambulatory stuff. Jim Dolly is the white coat investor talking about financial wellness. Jonathan Gall, I should say, from Mount Sinai, New York on economics and manpower. Bassem Abdelmalik from the Cleveland Clinic talking about non-OR anesthesia and airway management. Nadia Hernandez from UT Houston talking about regional anesthesia and ultrasound. And Dr. Duminda Wujisundara from the University of Toronto talking about preoperative evaluation and perioperative myocardial infarction. So we hope you can come join us later this year, or I should say at the very end of the January 2025. It's my pleasure to formally introduce Dr. Roman Dudaryk from the University of Miami. He's a professor there. It's interesting, you know, in different departments, there are different power centers in a department. And a lot of times that might be cardiac or it might be ICU. At Miami, as I can see, it is the trauma group. They are just outstanding.
It's very unusual, very unusual. I like this definition of power center of the department. It is very true.
Yeah, no, it's true. And he's also in charge of quality assurance in the department. You might want to screenshot this here. There's an excellent review article in JAMA just a couple of weeks ago on perioperative management of patients taking direct oral anticoagulants. So there will be a recording of this lecture, but if you want to read something about this or share with your colleagues, this is a great review article, and I'll also put the link in the chat. So Tracy, do you want to pull up some polling questions? And do you need for me to stop sharing my screen to do the polling?
I don't believe so. Do people see the poll?
I can stop sharing anyway. So
yeah, we can see the poll. Yeah, it's there.
Okay. So we have a couple of questions for you to answer here, please.
Actually, 3 questions. Do I need
I'm
to?
sorry.
Mm-hmm.
3 questions here. Do you have the ability to test for DOAC levels at your institution? Yes, no, I don't know. Then, do you trust your patients' self-report of when they stop their DOAC medication when deciding whether or not to do neuraxial anesthesia, or do you just blanket avoid? And the last question is, does your institution use a standardized online anticoagulation tool for decision-making in patients on DOAC medications? And are you able to see those answers there, Roman?
Yep.
All right.
I'm going to ask for a few more people, perhaps, to weigh in. Otherwise, I'll close the poll and share results.
Well, as Roman said, some people may be driving, some people may be on the treadmill, some people may be otherwise indisposed. So, you know, it looks like we got the votes that we're going to get here. So just to review, we have here, do you have the ability to test? 1 says yes, 3 say no, 1 says I don't know. Do you trust patients' self-report to do neuraxial? 4 say yes, 1 says no. And avoid. And then, does your institution use a standardized online tool? 1 says yes, and I presume the other 4 say no. So with that in mind, Roman, you want to take it away, please?
Yes. Let me share my screen. Can you see it?
I still see the poll.
It says,
I see the screen. Do people see the screen?
I can see it.
Thank you.
perfect. John, can you see it? You're the most important attendee. I cannot start without you seeing the screen.
No, man, go ahead. I got this cheap Chromebook. You know, it does funny things.
Okay.
Please carry on.
Okay, thank you. So we'll talk about peri-procedural management of dogs. And the objective of our talk will be quite simple. We'll talk about the mechanism, how it's relevant to clinical decision-making. We'll talk about reversal strategy, if patient has to undergo emergent or urgent surgery, and we'll talk about general approach for perioperative management for elective surgery. So this is going back to the story how I got interested in the subject. So we talked about Miami and how crazy it is, and we have a lot of people, a lot of driving. So it is interesting. If you look back, the first commercial about direct oral anticoagulants was filmed in Miami. And the lead actor of this production was this fine cardiologist who works in the South Miami Hospital, which is right here, and our trauma center right here. So it's about 23 minutes of driving. And we do have a lot of snowbirds, a lot of people who have atrial fibrillation. And needless to say, was this commercial that was advertising this huge benefit of novel class of medication for anticoagulation, which doesn't require monitoring. We became greatly concerned. And the reason we were concerned is this. Shortly after introduction, we started to see patients like this one with the CT scan, which, you don't have to be a neurosurgeon, neurologist to interpret that this patient had massive intracranial hemorrhage. So this benefit of not monitoring the anticoagulant came at very steep price at that time, that there was no reliable reversal strategy. And it became one of the most debated and challenging issues or tasks in perioperative medicine. So the first natural question that comes to mind: why do we need them? Why do we need dogs? And there is also some confusion in terminology. So DOAC stands for direct oral anticoagulants. When they were introduced, they were called NOACs, or novel anticoagulants. And after 10 years, hematologists realized they're not novel anymore, therefore we're going to change the name. If you look at Australian or New Zealand literature, they're still called NOACs. And what they've done is very clever. They're on the other side of the world. They have animals carrying babies, in the pockets. So they kept the name of NOACs, but they changed abbreviation to non-vitamin K oral anticoagulants. So it's all the same thing, right? So they work very different from vitamin K antagonists or warfarin. And the vitamin K antagonist inhibits production of liver-dependent anticoagulant factors 2, 7, 9, and 10. So basically, it makes the factors inactive, and therefore impedes coagulation pathway. What is very different and crucial to understand with DOACs, the level of the coagulation factors is normal, but DOAC is a direct inhibitor of those factors. So this is very simple depiction of coagulation pathway that we cannot remember. And the key point to understand that there are two large groups of direct oral anticoagulant. The first group works on activated factor 10 or 10A, and this is the common link of intrinsic and extrinsic coagulation pathway. Therefore, it is a perfect target to kind of disrupt anticoagulation pathway. And very conveniently, manufacturers designed or came up with the names that reflect, generic names reflect that this is 10A inhibitor, or also kind of known in blogosphere as Zabans or Exabans, whatever name you choose. So you have 10A in a name. And there is only one thrombin inhibitor. So thrombin is the kind of last factor before conversion of fibrinogen into fibrin. And the bigatran, which is the only thrombin inhibitor has TR in name, so it's very easy to remember which dog belongs to which group. So all factors considered, dogs have more good than bad. So there is no monitoring available, but that was the main reasons why they were introduced in clinical practice. The major problem with warfarin historically has been unpredictable response. So the INR, after you start anticoagulation with warfarin, the response was unpredictable. It can be therapeutic, can be supratherapeutic, and patient does not stay in this ideal anticoagulation window, predictable for a long period of time. So with dogs, the idea from the commercial standpoint was if you come up with a drug that has such a reliable therapeutic range, you would eliminate need for continuous monitoring and therefore greater increased compliance. If compliance is high, the consumption of the drug also will be high and people will have better outcomes. So kind of, the company benefits because they sell more drug, but also the patient benefits because they're predictably and reliably anticoagulated. But again, at the beginning, it came with the steep price of very limited reversal option and no monitoring being available if patient has to undergo emergency or urgent surgery or procedure. On the good side, though, the dogs overall have lower risk of bleeding than warfarin, especially intracranial bleeding. So all the large studies that compared warfarin to dogs demonstrate that the dog have overall across the border less chance of bleeding, most likely due to inability to overshoot therapeutic range. So you can have the patient with INR of 6 or 7 if they kind of overcoagulate as warfarin, but with dog it doesn't happen. They usually stay in the therapeutic range. And again, no monitoring needed, increased compliance, there is excellent dose-response relationship, and there is limited, if any, food and drug interactions. So the first practical point that I want to discuss is monitoring, and it has been persistent problem with dogs since introduction. So conventional coagulation tests may give you some information about degree of coagulation, but they are highly unreliable. But there are some, there are still some useful information that we can get from conventional coagulation tests. When we look at the begetran, you can use APTT as qualitative test. What does it mean qualitative? It means there is no linear relationship between APTT level or APTT number and degree of anticoagulation. Okay, so it's not like high APTT means high DOAC concentration. It means there is some DOAC on board. And when APTT is normal, you most likely can exclude therapeutic concentration of the begetran. There is also a very old test called thrombin time. So it's very sensitive, available in majority of labs. It is highly sensitive. So if you really want to exclude any DOAC on board, like almost no molecules of DOAC on board, if you do it and it's normal, it means there is not even a residual concentration. So it may be relevant in the cases, let's say, when you plan to do spinal anesthetic and you're not sure about, if the patient is given the right information when they got the right dose. So if you really want to exclude any residual DOAC concentration, you can do thrombin time. The problem is, if it's positive, doesn't mean that bleeding would be clinically significant, right? The thrombin time may be elevated, but it may be inconsequential in terms of clinical bleeding. And PT-INR is completely useless to measure any of the begetran concentration. The best test for the begetran in places who have this test, it's called Hemoclot. So initially it was not approved in the United States. It has been used only in research centers when they did those trials comparing dogs to warfarin, but now some places have it. And if it's available, it works great. For 10A inhibitors, situation completely different. So 10A inhibitors actually are slightly, their concentration slightly correlates with INR. So if you look at INR level and concentration of rivaroxaban, so therapeutic range of rivaroxaban is about 150 to 300 nanograms per liter, and that's where you see this slight increase in INR. But you can see from the slide that the degree of INR elevation is also, is in a very wide range. So you can have super high numbers with INR of 3 and 4 and 5, and patient may have barely any DOAC on board, or you may have INRs in therapeutic range and patient is, right in the therapeutic range. So again, there is some correlation, but it cannot really be used clinically. The best test for 10A inhibitors or Zabans is agent-calibrated anti-factor 10A activity. So the agent-calibrated portion is the key, because a lot of hospitals have anti-factor 10A level, which is used usually in intensive care unit for titration of low molecular weight heparin. And it's not the same thing. So if you use non-calibrated anti-10A activity, it will have similar effect as PTINR. There will be some correlation, but it really doesn't have linear correlation with DOAC concentration. If you have agent calibrated, then you have this perfect, ideal concentration and anti-factor 10 activity response level. So it's ideal test, but again, not widely available, unfortunately. And I've been saying this, not widely available for the last 10 years. It's still, because what happens with those tests, there is very limited clinical need, and they're quite expensive, and therefore hospitals kind of reluctant to get them on board. If you have those tests around, there is only one number to remember. It's for both of them. It's 50 nanograms per ml is a cutoff of clinically significant DOAC concentration. So if you have this test available and you run it and it shows concentration less than 50, it means that concentration of DOAC is clinically insignificant and unlikely to be associated with bleeding, and you can proceed with surgery without any reversal or any additional steps, and there is no need to delay surgery. So there is minimal, if any, bleeding risk. Frequent question that comes up, what about viscoelastic testing? What about TAG and ROTEM? Can they detect DOACs? And unfortunately, it's the same problem as with conventional coagulation tests. They cannot detect DOACs. And we had a patient a few years ago who was on rivaroxaban, actually took additional dose before going on transatlantic flight in order to decrease chance of PE and DVT, which was recommended by his primary care physician. Unfortunately, he slipped and fell and had a laceration of his scalp 2 hours after he took the pill, so right at the peak effect of DOAC. And when he came to our trauma center, viscoelastic testing showed that there is no anticoagulation whatsoever. So his TAG was completely normal. In fact, slightly hypercoagulable, and had completely normal INR despite receiving 3 units of Paxil transfusion due to massive bleeding from the scalp before it was sutured. So this dilemma of lack of reliable clinical laboratory tests to detect DOACs and predictable onset and duration of action led to this dichotomy in terms of how we should gauge the degree of anticoagulation. So initially, there was this two camps. Should we invest into laboratory strategy and develop tests that are widely used for DOACs, or should we use this predictable onset and duration of action to extrapolate from the last dose if the patient has any residual anticoagulation? And it seems to be, over this 10 or 12 years since DOACs were introduced, the second concept of pharmacokinetic strategy has won. And the reason for that, DOACs have, as I mentioned, very predictable onset and duration of action. So if you look at all of them roughly, kind of rounding up the numbers, they have half-life of about 12 hours, with the peak at 2 hours. And they're completely cleared at 5 half-lives, and usually at 2 half-lives or 24 hours, they become subtherapeutic. So we can use that information to extrapolate the concentration of DOAC and degree of anticoagulation if you know the last dose when the medication was taken. That was adopted by different society guidelines. The first one was Society of Neurochirurgical Care, and they stated that time and amount of the last ingested dose and renal function are the best estimate of anticoagulant exposure. And this is the key information to decide if the patient has to be reversed before the procedure or if they have intracranial bleeding. So next point I want to discuss is how do we reverse those direct oral anticoagulants in the settings of emergency surgery. And before I go into details, I want to go over kind of big concepts that I see frequently misunderstood. So the first concept is that FFP does not work for DOAC reversal. It works well for warfarin reversal because with warfarin, you have decreased concentration of factors. So when you give FFP, you replete those factors to a physiologic level and therefore restore coagulation or ability to make clot. As I explained previously, with DOACs, concentration of factors already normal. DOAC do not inhibit the level or do not decrease the concentration level of the factors. They're active inhibitors of factors which are present. Therefore, if you give those factors in the form of FFP in physiologic doses, the DOAC, which is present in the blood, will inhibit the factors contained in FFP and there will be no effect on hemostasis. And therefore, again, FFP is not an option, is not useful to reverse direct oral anticoagulants. Next point I want to make is you should never reverse anticoagulants, either warfarin or DOACs, for elective surgery. And the reason for that is there is a reason why those patients receive anticoagulants. They're at very high prothrombotic risk, either due to atrial fibrillation or DVT or VT, PE, whatever the reason might be. So if you have surgery, which is, it's already prothrombotic state due to inflammation, immobility. On top of that, you either give very high concentration of coagulant if you give PCC or FFP, or you reverse DOAC completely, and that creates very high risk of thrombosis. Some estimates suggest that the risk of thrombosis can be as high as 10%, generally from 5 to 10%. So you can imagine if patient has 5 to 10% risk of stroke, PE, or DVT after reversal, that would not be acceptable for elective procedure. Therefore, you should never reverse those medication for elective procedure. Time is the reversal in those cases. You have to wait for the patient to be, have spontaneous reduction in anticoagulant activity. And next, the point I want to talk about, what is significant bleeding? Because as I mentioned, on the previous slide, reversal is not a benign intervention. So which bleeding is deemed significant to consider reversal? And we talk about bleeding, we should think about anatomically significant bleeding and physiologically significant bleeding. Physiologically significant bleeding is very simple for any anesthesiologist, is when the bleeding leads to hemodynamic instability. When the patient becomes hypotensive due to bleeding, this is grade 3 shock by American College of Surgery classification of hemorrhage, and therefore they need transfusion of blood. So that is degree of bleeding that is require certain reversal. When you talk about anatomically significant bleeding, we think about a small amount of blood, which may be inconsequential from the standpoint of hemodynamics, but if it bleeds into the head or spine or the eye, the effects of that would be detrimental. So that's another area. And in practice, I would say that is the most likely reason for reversal. We almost never reverse direct oral anticoagulants. I recall only one case when we had to do it for orthopedic surgery, but I recall plenty of cases when we had to do a reversal for intracranial surgery, usually for subdural or epidural hematomas. And the last clinical point I want to make is when somebody is anticoagulated and they undergo a massive surgery, either due to trauma, intracranial surgery, or something else, GI bleeding, for example, the reversal should not replace the good resuscitation with 1-to-1-to-1 ratios of transfusion, administration of TXA, and overall good hemostatic management. It just takes anticoagulant out of the equation, but the surgery is still going. They still cut the tissue still bleeds. So good hemostatic resuscitation is still essential for those cases. So now I want to talk about just the case that we had, and on the example of this case, we'll look at the reversal option and illustrate how reversal should be done, in practical settings. So in clinical settings. So we had, let's say, 83-year-old man who was anticoagulated with the rivaroxaban for atrial fibrillation. Last dose was 12 hours ago. patient was admitted with massive subdural hemorrhage. You can see it on this CT scan of the head. You don't have to be, again, neurosurgeon to recognize there is a problem, and scheduled for craniotomy. So what would you do in this case? The options are give FFP, give PCC, give idursulizumab or Prexbine, or do nothing and just proceed with surgery. So you can put answers in the chat, and I'll go through all the options, and we'll have answer few slides later. So when we think about reversal, ideally we want to have on-off switch, right? So we want to give the patient anticoagulant when we want anticoagulation to achieve therapeutic level, but when we want to reverse it, we give reversal, and it completely, restores normal coagulation profile. And in fact, with idursulizumab, that was achieved. The idursulizumab is a reversal for the dabigatran, and when it came to the market, I think in 2015, it was actually, I think it was even on CNN how miraculous this drug was. And the reason it had so much publicity and there was so much press by the company, because the study that demonstrated efficacy of idursulizumab was very well designed. So what they've done in this study that was published in New England Journal, besides laboratory parameters, those hemoclot tests, and laboratory parameters to demonstrate decrease in dogs, they also used a clinical endpoints of bleeding. The surgeons after administration of reversal, scored the degree of hemostasis, and they looked the amount of blood given, and they showed that that there was effective hemostasis within minutes. It was achieved in 98% of patients who were anticoagulated. So how does it work? Essentially, it is a monoclonal antibody that blocks attachment of the dabigatran to thrombin. So the dabigatran is thrombin inhibitor, and Prexbine is a monoclonal antibody specific to the dabigatran that blocks attachment to thrombin. It is very easy to administer. It is one dose fits all. Each vial is 2.5 grams. So the total dose is 5 grams. It's 2 vials. They recommend to be given over 10 minutes, but can be given as a push safely. There is no problem. When we had to do it a couple of times for jar bleeding, we just kind of gave it as the push, and there is no. It's similar to the way we give antibiotics in the operating room. Generally in ICU they give it as a slow drip, but we push it and it's not a problem. For 10A inhibitors or Zabans, the most common reversal that is available in clinical settings in the United States is prothrombin complex concentrate, or PCC. And the idea with prothrombin complex concentrate is to provide enough coagulation factors in a very high supraphysiologic concentration to exceed binding capacity of the inhibitor. So this is my kind of schematic illustration how it works. So PCC has factor 10A, and if you give it that much in very high concentration, it just overwhelms the present inhibitor and restores coagulation. It is not FDA approved, but it has been used for the purpose of Zabans reversal for many years by now. There are 2 dosing regimens when you have to administer PCC. So in the past, we used to rely on weight-based regimen when you would give 25 units per kilogram and would repeat if needed to the maximal dose of 5,000 units. But more and more places now switching to fixed dose, and we also switched to the fixed dose. So essentially, it's 1,500 units for all patients, and then observe the clinical hemostasis and decide if additional dose has to be given. The advantage of the fixed dose, there are 2 advantages. So first, and there has been several studies looking into efficacy, and the fixed dose appears to be as effective as the weight-based dose. So with the fixed dose, first of all, it's cheaper because this drug is very expensive. We'll talk about cost shortly, but also because the dose is lower. most likely there is less chance of prosthrombotic complication if the total dose of PCC is reduced. Besides PCC, there is a agent-specific reversal for 10A inhibitors that has been around for a while, and it is called adnexanet alpha. So it is a universal reversal of all anticoagulants which work through factor 10A. And while it's mainly advertised and approved for dogs, if you give it, let's say, hypothetically, for heparin or low molecular weight heparin, it also works. So it's almost universal reversal of all anticoagulants. And it has very clever pharmacological design. So what they've done with adnexanet, it is essentially a decoy factor 10A. So it looks exactly like factor 10A, but it lacks the platelet binding domain. At the same time, has very high affinity to rivaroxaban, apixaban, and doxaban, and binds to it and holds it, preventing connection of this inhibitor to actual factor 10A. There are two dosing regimens of adnexanet. So there's low dose and high dose. So contrary to Prexbind, which is very easy to administer, it's kind of 5 grams to everybody. The administration of adnexanet way more complicated. So there are two dosing regimens, and it has two components. Each regimen has two components. It has a bolus component and infusion component. And infusion has to be given over 4 hours. So it's not as user-friendly as Prexbind to administer. And the regimen depends on actual dog regimen, if it's BAD or daily, total dose, if it's high or low, because if it's BAD, it's a high dose, and the last dose, the time from the last dose. So generally, majority of patients receive the low dose regimen, because if the last dose of medication was taken more than 8 hours ago, patient automatically becomes the low dose. So if it's less than 8 hours, then depending on strength of the last dose, it is adjusted as the high or low. So again, it's a bit more complicated. So you probably have to reference this, or whatever reference do you have to decide. Pharmacy probably will help you with that, because they due to the cost, they will be all over you to help you decide what kind of dosage regimen should be used, and they always most likely push for the lower dose because it is very expensive medication. Again, it's just bolus and infusion. So for the low dose, it's 400 milligram bolus followed by 4 milligrams per minute infusion, and then for high dose, it's 800 milligram bolus followed by 8 milligrams per minute infusion. So essentially just double the dose, both for bolus and infusion. You can see here it's 5 vials versus 9 vials. So the question is how effective this complicated regimen and this very fancy medication in reversal of anticoagulants. And unfortunately, when we compare this to other reversal options for direct Roman inhibitors, the factor 10A reversal is not great. So first of all, the study that demonstrated efficacy of adnexanet, the first study, they excluded surgical patients. So they just did it. Basically, if the patient was supposed to undergo surgery, they excluded. And I suspect the reason it was done because of logistics. Because if you think about it, those studies are notoriously difficult to do due to emergency nature of the procedure. And with Prexbind, it's just, easy push or quick drip and the anticoagulant reverse. If you have to come up with this low dose, high dose, you have to calculate how much to give, and you have to give it as infusion over 4 hours. I mean, who's going to wait for all that? I think because of that, in perioperative period, those considerations were too messy, and they decided just exclude all surgical patients. So they just, basically look at the small intracranial hematomas, which didn't require surgery, or GI bleeding, which was non-operative. But nevertheless, they demonstrated hemostasis in 82% in that limited population. Another interesting point, some patients actually had rebound. So if you look at the concentration, initially there is a drop, when you use those gold standard anti-factor Xa tests, but later on there was some rebound. You can see it here. Some of the patients actually rebound in the therapeutic range. Therefore, that infusion is essential. You can't just give a bolus and forget about it. That infusion is essential to maintain this degree of inhibition of anticoagulant for at least 4 hours in peri-procedural period. So now we have dilemma, right? We have one medication which is FDA approved, which is Annexonet, very difficult to administer, very expensive, and we have PCC. The question is which one is better. So there has been several observational studies that seems to have equivocal results, right? There was not a single study that was observational study that compared PCC versus Annexonet that showed Annexonet is superior. There was no difference in hematoma size. There was no difference in functional outcomes, but there was huge difference in cost. So if you look at the reversal on average, four-factor PCC reversal, the dose that I mentioned is about 5,500. Again, maybe different in each hospital because each hospital has different purchasing prices. That's a free market. And with Annexonet, initially it was almost 50,000. Now it went down slightly to only 25,000. So needless to say, there's no major clinical benefit. It's very difficult to justify the price. So this status quo was maintained for the last 5 years up to, I think, in June or July, there was this very anticipated publication that came out. And what they've done in this study, which was sponsored by maker of Annexonet, Portola, what they've done, they compared Annexonet, high dose and low dose, depending, on the algorithm of the last dose of DOAC, and if it was given a high or low dose, to a usual care. So usual care in majority of centers was actually prothrombin complex concentrate. As endpoint, they selected hematoma expansion because majority of those patients require reversal, have intracranial bleeding. They say, if hematoma expands by less than 35%, it is a success. It is a good result of reversal. So there was a small edge of Annexonet versus usual care being PCC. So Annexonet versus PCC shows slightly better suppression of hematoma expansion. But it came at pretty steep price. When they look at incidence of thrombotic events, it was 10% in Annexonet group. Remember, I told you that the reversal is not a benign thing, that the reversal is in observational study. Reversal is associated with 10% risk of thrombosis. Here we go. So about 10% risk of thrombosis. It's not a benign thing to take. And those thromboses are not benign either. It's stroke or DVT or pulmonary embolism. And usual care, which is PCC, was 5%. So incidence of thrombotic events was double in Annexonet group. And incidence of ischemic stroke, although there was not enough patient to do statistics and do p-values, if you look absolute numbers, it was pretty staggering. There was 6.5% of patients had ischemic stroke versus 1.5% those who received PCC. So from what I understand, and I look at several editorials and other sources, it is very difficult now to justify use of Annexonet for reversal of Zabans or Exabans, whatever you call it, in clinical settings due to this very high risk of prothrombotic complications. So now we're going back to our patients. So our patient received 25 units per kilogram. It's a weight-based dose. The case has happened before we switched to a fixed dose. So total calculation was 1,500 units. That's why it is the most common empiric dose. Underwent craniotomy, hematoma was evacuated, and he was discharged without any neurological deficits. But the story didn't end there yet. So patient was readmitted a few weeks later with submassive pulmonary embolism that required administration of low molecular weight heparin and was discharged a few days later. And the reason it has happened because with reversal, again, we create a massive prothrombotic response, but at the same time, there's a reluctance to resume anticoagulant after that. And this is a major problem that usually ICU or floor has to deal with. The reversal is one part, but anticoagulation has to be resumed at some point when hemodynamic stability is achieved. So, to summarize, for emergency surgery, what is the suggested approach? If you have monitoring, you would check for residual level of anticoagulation. And if it is less than 50, patient has DOAC concentration on subclinical level, and it is safe to proceed to surgery. That concentration most likely would not lead to any bleeding. If patient require urgent surgery, if it's 6 to 24 hours range, and if you don't have ability to test DOACs, then the best option is proceed with surgery and have a reversal ready. Basically, what it means in this time frame, depending if you're close to 24 hours or it's closer to 6 hours, depending on the surgery itself, then you make the decision for reversal. So I would say if the surgery is spine or head, if it's intracranial or fusion procedures, then I would proceed with reversal if it's less than 24 hours. If it can wait more than 24 hours, which is usually orthopedic surgery, then I would suggest to wait rather than go for reversal. And for semi-urgent surgery, when the time of operation is more than 24 hours, so 25 to 48 hour window, then the expected management just to wait for the degree of anticoagulation to spontaneously subside and then proceed with surgery is the most prudent approach. So to summarize this approach, you probably should consider reversal for intracranial and spine procedure if the last dose is less than 48 hours ago. If it's more than that, then you safely can proceed. If the surgery can wait, then you should probably negotiate and suggest at least that maybe you should wait another 6 hours or another 12 hours and then pursue the surgery, because at that time there would be very predictable reduction in anticoagulant effect. So the last point we want to talk about is perioperative anticoagulant management or DOAC management for elective procedures. Most common indication for DOAC administration is atrial fibrillation. It essentially replaces the warfarin, and VTE, which includes DVT, deep venous thrombosis, and pulmonary embolism. It kind of goes under the new name of venothromboembolic disease. For mechanical heart valves, the warfarin is still the king. There is no the study that has compared warfarin to DOACs suggested that DOACs are not as effective as warfarin, and the warfarin is still a drug of choice for anticoagulation for patients with mechanical heart valves. When we think about perioperative management, there is a risk of bleeding because patients are anticoagulated. But if anticoagulation is aggressively either reversed or the whole time is too long, then there is increased risk of thrombosis. Risk of bleeding is determined by what kind of surgery patient undergoes. So there is generally we group them into low risk, moderate, and high risk surgery. So low risk, it's dental extractions, gyroscopes without the biopsy, coronary angiograms, pacemakers. Moderate risk is usually laparoscopic surgery and small orthopedic surgery like wrist, ankle, and the high risk is everything else. So in the past, with warfarin, what we have done kind of to minimize this degree of patient being at the high thrombotic risk, we used bridging, right? We would stop warfarin, start either low molecular weight heparin or heparin infusion in the hospital, and then stop that 24 hours or 6 hours in case of heparin before the procedure. And the rationale for that would be, the patient would be, if you just hold the warfarin, patient would be, exposed to thrombotic complication for a very long time, because kind of they would fall out of the therapeutic range, drip down, and the surgery would happen, and then with resume warfarin, and patient slowly would climb back to the therapeutic range. With DOAC, it is not necessary because DOACs have very predictable onset and offset of action. So you stop it, essentially the concentration drops down pretty precipitously. So the patient within 24 to 40 hours restore clotting capability. And then when you resume DOAC, within 2 hours, they are back in therapeutic range. And for that reason, the key point to remember, DOACs almost never require bridging. There has to be something highly unusual, some degree of mismanagement to have any kind of bridging. It's not a thing with DOACs. It's just discontinuation in the proper time frame. And because of that, I think this is probably the most important slide for practice. So because of that, the perioperative management of DOACs for elective surgery now has been greatly simplified. And if you imagine the surgery takes place on this day or day 0, what you have to remember is following. You look at risk of bleeding. So there is minimal, moderate, and high risk of bleeding. So if the risk of bleeding is minimal, then there is no need to stop anticoagulation. Okay, so you can continue, but what they need to continue is on the day of surgery is the only day when you hold DOAC, either hold it or take it after the procedure. And it would be, again, dental extraction, pacemaker placement, coronary angiogram, or endoscopy without the biopsy. For moderate risk procedure, you would hold the DOAC for 1 day, and this is this column, easy to remember. And for high risk procedure, you would hold DOAC for 2 days. As simple as that. So either 1 day or 2 days, and that's most relevant to the operating because usually we don't do anesthesia for dental extraction. If you have to do this multiple teeth and oral surgery, then it becomes moderate to high risk, and therefore you have to probably stop it. So this is has limited application except pacemakers and endoscopies. So 1 day, 2 days. There is one outlier here, and this is the dabigatran, and it has minimal, if any, clinical relevance. So this interruption of 4 days for the dabigatran is applicable to patients, only those who have significant degree of renal dysfunction. And the dabigatran kind of fell out of favor. The vast majority of patients who come on DOACs, they actually come on 10A inhibitors. And the dabigatran, only a few patients have it. And if they do have it, they most likely will have normal renal function. Nobody will continue the dabigatran in somebody who has any kind of chronic kidney injury or renal insufficiency, because the first reason why the dabigatran fell out of favor is because it's renally excreted, and all those patients are at risk of kidney problems, and therefore cardiologists don't like to use it in those patients. So now this is a summary of simplified approach for elective surgery. If it is a minimal bleeding risk, skip the dose on the day of surgery, right? The guidelines will say continue, but what they mean, you don't take the pill of direct oral anticoagulant and then go for procedure. You just either skip it on the day of surgery or take that pill after the procedure took place. Either option is acceptable. If it is low or moderate bleeding risk, you skip 1 day. If it is high bleeding risk, you skip 2 days. So now, armed with all that knowledge, we're gonna go through a couple of practical cases. So 75-year-old female, history of coronary artery disease, congestive heart failure, atrial fibrillation, diabetes. She's supposed to undergo defibrillator replacement. She took rivaroxaban yesterday, and cardiologists say, let's go, don't worry about it. So what would you do in those circumstances? Option 1, agree with cardiologist and proceed. Option 2, cancel the case. Option 3, give FFP and proceed. And option 4, give PCC and proceed. So out of all this option, you should never argue with cardiologists. And the right answer is agree with cardiologists and proceed. This is a minimal bleeding risk procedure. It's right here, right? So permanent pacemaker insertion. So therefore, you just omit the dose on the day of surgery. And there was actually very good study done looking into that. So in Bruce control trial, they compared, in multi-center RCT, they compared last dose of DOAC the day before, interruption of 12 hours versus last dose of 3 days before, for those patients undergoing any kind of cardiac device placement. and the incidence of hematoma was the same in both groups. So you don't have to interrupt dog for ICD placement or placement replacement. Only the days of surgery, that's when you have to omit it. Case number 2, 76-year-old female, history of VTE about a year ago, atrial fibrillation, myocardial infarction, diabetes, CHF on apixaban, 5 milligrams BID, last dose 3 days ago for elective hip replacement. What would you do? Check PDT and proceed. B, just proceed. C, cancel the case. And D, bridge was happening. As we talked about, heparin is not an option. Cancel the case. We don't really want to do that. And we don't have to do it because patient underwent appropriate interruption. So the last dose was three days ago, so it's 2-day interruption. If you add the day of surgery, and it was appropriate for this procedure, so patient is good to go. This is interesting one. So this is the practical challenges sometimes we face. 76-year-old female, history of CHF, diabetes, CVA, hypertension, DVT on previous admission 2 months ago, scheduled for elective shoulder arthroplasty, and orthopedic surgeon wanted to be, very vigilant with anticoagulant interruption. So he suggested to stop anticoagulation 7 days ago. The patient shows up to your operating room. So what are the options? Proceed, cancel the case, discuss with the patient and surgeon, risk of proceeding versus resumption, or check anti-10A activity and proceed. This is a real life scenario. It happens all the time. So patient will stay in the window of high risk of thrombosis for unnecessary long time, right? Because if you are 7 days without anticoagulation, the risk of thrombosis is increased, and surgery adds further risk of thrombosis. So I would discuss this increased risk with the patient and the surgeon, but kind of damage is done, right? Patient already went through the 7 days. So I would talk to the patient, talk to the surgeon, explain there is higher risk of stroke because of that, or any kind of thrombotic complication. But nevertheless, because that interruption already took place, I would probably be okay with proceeding, just add documentation that this increased risk of thrombosis has been discussed with the team and the patient. They're okay to proceed.
So Roman, hold up. A question.
Yeah,
so everyone in
tell
the
me.
chat is saying it's always easy when you're not sitting there in the OR to cancel the case, right?
Yeah.
And everyone in the chat is saying, cancel. And so, I mean, because yes, the damage is done in terms of coagulability, but then you're going to add surgery on top of that.
Correct.
So what's the rationale? How is it in the patient's best interest to proceed?
Because I think, okay, so it can go both ways. I said, if patient and surgeon are okay with accepting that higher risk, because I understand what you're saying. So the surgery will add additional risk of thrombosis, but 7 days of interruption has happened already, right? Has happened already. And the patient presumably doesn't have stroke or thrombotic complications, right? So if you proceed, the risk is taken already, versus if you cancel the case, the risk has been taken, then you have to stop it again for a couple of days, and then you're going to proceed again. Alternative option, start low molecular weight heparin in therapeutic dose, admit the patient for 24 hours, 48 hours, do, scan for DVT, and if it is negative, then proceed. But it gets very complicated, See,
if that patient has a stroke, it's your fault.
If you didn't discuss increased stroke risk, it's my fault. But if the surgeon and the patient accepted the risk and decided to proceed, that's the acceptance of the risk. I'm going to tell them there is a 10% risk of stroke if they proceed.
No shoulder is worth 10% to me. Anybody else have
I
something
agree.
to say about this?
I agree. But in real life, I know what will happen. In real life, most likely people will proceed.
Anybody else? All right, carry on, sir.
But cancel is a viable option. Cancel, I want to be contrarian. So the cancel is another great option. And the reason for that is, if you look at this specific patient, if you look at two parameters why patient is anticoagulated. The first is risk of stroke due to atrial fibrillation, which is assessed by CHA2DS2-VASc score. So if we plug in, there are plenty of calculators. This is just one of them. If we put the age, CHF, hypertension, history of previous stroke, diabetes, and gender, we come up with a score of 8, which is high. So that's one component. Second component is chance of recurring DVT. So in this case, if you stop anticoagulation in the first months, the chance of recurring DVT is about 50%. At 3 months, it's 10%, and it reduces to less than 5% at 3 months. So therefore, no elective surgery probably should take place within 3 months after patient has DVT, which requires anticoagulation.
So Dave Shantha in the chat asked, is this elective?
If this is completely elective, you should postpone it to 3 months. Correct.
Okay. And this surgeon, is this surgeon just ignorant or just overzealous and only cares about his or her hemostasis?
I think all orthopedic surgeons cares about hemostasis and bleeding into the joint. That's the only way for the patients to die, bleeding into the joint. That's it. There is no other way. They don't think about bleeding into the brain or stroke.
Okay.
So the last case is 68-year-old male, scheduled for total knee arthroplasty, history of atrial fibrillation, CHF, reduced ejection fraction. He is on apixaban 5 milligrams BID, and generally in your place, imaginary, like in our place, usually those cases are done on the neuraxial. So vast majority of our knees are done on the neuraxial spinal anesthesia, and office knows about that. So ortho office calling you and asking what they should do about apixaban in the context of planned neuraxial anesthetic and what they should tell the patient. So the options are neuraxial is contraindicated, just hold it 1 day and proceed with surgery. Option B, hold it for 2 days, plan for neuraxial. Option number 3, hold for 3 days and plan for neuraxial. And D, hold for 1 week and plan for neuraxial. So the right answer, this is off the beaten pathway. I didn't mention this at the beginning because this is different set of guidelines invented by anesthesiologists, not hematologists, and we are very careful. So if you look at European Society of Anesthesiology and other guidelines, they both suggest 3 days interruption of anticoagulation with DOAC if neuraxial anesthetic is planned. It's probably overly conservative, but because of detrimental effects of intraspinal bleeding or hematoma, I think it's probably reasonable to be so conservative. The ASTRA guidelines, by the way, are very old. They are from 2018, I think. Europeans are much newer than 2022. But it still both suggests interruption for at least 3 days. For the Dabigatran and others actually suggest 4-day interruption if you plan neuraxial block. The same applies for any kind of interventional procedures for pain management, the facet block and epidural steroid injection, spinal cord stimulators, etc. So those guidelines, they are simple, but at the same time, when you face with decisions, sometimes kind of, it's difficult to reconcile the facts and put it all together. So there are several apps, there are several algorithms. This is probably one of the better ones. It's by Thrombosis of Canada. So the article that you suggested, it's actually an article that was published in JAMA. The main author is actually probably the #1 expert involved in those guidelines. I think James Dudaryk is his name. And he is the one who runs this society, Thrombosis of Canada, and he updates the guidelines. So he is like the utmost authority in the field. If you want to use the guidelines of the app, this is the one I would go to. It's free. You can download it in Apple Store and Android. It's very easy to use. So in the summary, standard coagulation tests show insufficient coagulation with dogs. For dogs, for the begatron, you may use thrombin time or APDT as a rule-out test. For Zabans, you may use PT-INR as a rule-out test, meaning if the level is completely normal, most likely you don't have any residual anticoagulation. At the same time, time from the last dose and renal function are the best clinical estimates of residual anticoagulation. Prexbine is a specific reversal for the begatron, but the begatron is rarely used. You almost never see it nowadays. Majority of patients are anticoagulated with 10A inhibitors. So for those, Dexant is a specific reversal, but it has increased risk of thrombosis. Four-factor PCC is viable alternative if Dexant is not available or too expensive, or you may decide to avoid this risk of thrombosis. For low risk bleeding procedure, there is no interruption needed, but it means that the dose of anticoagulant should be taken after the procedure, not before. For dogs, perioperative bridging is not indicated. I'm going to put the reference again for this article that you mentioned. I think it's a great review. There's also podcast, so you can listen to the podcast. I think it's well done and touches some very important points. And we can have question and discussion. Thank you.
Thank you, Roman, for addressing obviously a very important topic and making something that seems complex not as complex as it might seem. So thank you very much. Again, I've put the link to the review article that he has up here, a short URL, or you can screenshot that. We have a few people left in the room. If Ken McNeil's given a thumbs up, you can stop sharing your screen, I guess, unless there's anyone. Does anyone want to see any more slides again? Is everyone kind of happy with what's there? Seems like everyone's quiet there, so we'll give people a few minutes and a few seconds.
You know what? I'm curious. Somebody responded they have monitoring. I'm really curious if this was an accident or they really have monitoring, because we don't have it. We don't have agent-specific anti-factor A levels. Very few places do. Like Duke, for example, has it, but the reason they do have it because they were part of the trials. So usually what happened, those trials were multi-center trials looking at dogs for atrial fibrillation centers who were part of the trial. They had ability to test for it. And they kind of, it had like a legacy to keep the test available. But it's still very rarely you have those tests available for clinical use.
Okay. Well, again, we invite you to join us in Grand Cayman at the end of January. Destination CME is the website. We'll be sending out this video. Roman's been kind enough to allow us to record and share it. So you might choose to share this with your colleagues, or maybe invite them to do a grand rounds at your institution. And we thank you for spending part of your evening with us. Roman, thank you very much.
Thank you, John. It was a pleasure. Thank you for showing up, everybody. I know it's not easy.
Take care.
Bye.